Okay. Welcome, everyone. This is Dr. Donna Rich and Dr. Denise Goddard, and we will be discussing motivational interviewing today.
So the objectives of this webinar are that after completion, the learner will be able to describe the concept of motivational interviewing and to understand the utilization of motivational interviewing in the clinical setting. So we're going to start first with what is motivational interviewing? This is a method of communication for eliciting and strengthening the patient's motivation for change. It is patient-centered and it is goal-directed. So motivational interviewing was developed in the 1990s by William Miller and Stephen Rolnick. Motivational interviewing builds on Carl Rogers' humanistic theories about one's ability for exercising free choice and changing through a process of self-actualization. Motivational interviewing is designed to motivate behavioral change. It emphasizes negotiation over conflict. It focuses on developing and encouraging the patient's autonomy, self-confidence, and determination for change. Motivational interviewing is a technique in which you, as a clinician, become a helper in the change process and express acceptance and encouragement. Motivational interviewing is a counseling method that helps a patient resolve hesitant or uncertain feelings and insecurities in order to find the internal motivation that he or she needs to change his or her behavior. It is a practical, empathetic, and short-term process that takes into consideration how very difficult it is to make difficult and sustainable life changes. The clinician's role is directive, with a goal of eliciting self-motivational statements and ultimately to obtain behavioral change from the patient. Motivational interviewing is often used to address the management of conditions such as diabetes, heart disease, asthma, obesity, or addictions to substances like nicotine, alcohol, or drugs. This intervention will help patients to become motivated to change the behaviors that are preventing them from making healthier choices and achieving their optimal health and well-being. Motivational interviewing is also appropriate for angry or hostile patients. These types of patients may not be ready to commit to change, but motivational interviewing could help them move through those emotional states to find their individual motivation for change. Motivational interviewing emphasizes negotiation over conflict in the counseling relationship and has a focus on developing the individual patient's autonomy, confidence, and determination for change. In their book, Motivational Interviewing, Preparing People to Change Addictive Behavior, Miller and Rolnick identified 5 principles of motivational interviewing. The clinician needs an empathetic, supportive, yet directive counseling style in order to provide a safe and comfortable condition under which change can occur. The clinician will need to actively listen, be able to understand a speaker's ideas, and then offer the idea back to the speaker to confirm that the clinician has understood correctly the patient's idea. The clinician will be able to identify discrepancies between continuing the patient's current behavior versus achieving the patient's goals and optimal health. Challenging the patient, direct argument, aggressive confrontation will only likely increase the patient's defensiveness and reduce the likelihood of positive behavioral change. The clinician should adjust to client resistance or defiance with alternative suggestions, solutions, or strategies rather than opposing the resistance directly. The clinician should offer support and encouragement for the patient's self-efficacy and optimism. Motivational interviewing is defined by a partnership between the clinician and the patient, which allows and encourages the patient to think about his or her behaviors and goals. Evocation being about and acknowledge current behaviors, to imagine optimal health and current behaviors. So the clinician needs to show compassion and acceptance of the patient's experiences, thoughts, goals, and perceived barriers. The likelihood for positive change occurs more readily when the clinician connects the change with what the patient values and what the patient sees as his or her own goals and optimal outcome. Confrontational styles or heavy persuasion are likely to increase resistance and should be avoided. Motivational interviewing is based on a theory that the motivation that is necessary for change to occur resides within the individual and is achieved by determining and encouraging the patient's personal goals and desires and their ability to change. It's based on allowing the patient to interpret and integrate health and behavior change information as they perceive it to be relevant to his or her own situation. Motivational interviewing acknowledges that the patient is the expert in their own life. Motivational interviewing assists the patient to become motivated to change the behaviors that are preventing healthier choices. This counseling method works well with individuals who start off unmotivated or unprepared for change. Positive change occurs more readily when the clinician connects the change with what is valued by the patient. Motivational interviewing promotes autonomy by holding the patient responsible for finding practical solutions to his or her own problems. And it supports the individual in developing creative ideas for change. It then encourages his or her belief that change is indeed possible. The process is twofold: to increase the patient's motivation and then for the patient to make that commitment to change. Motivational interviewing encourages a person to develop personal motivation for engaging in the change process. During motivational interviewing, a person will consider why he or she is resistant or ambivalent to change, and then identify and be able to articulate reasons for change. The clinician will encourage the patient to define the problems that he or she is facing and to actively develop solutions for those problems. Motivational interviewing addresses the patient's struggle, defiance, or pushback against change by actively involving that individual in the problem-solving process. Motivational interviewing encourages self-sufficiency and independence by holding the patient responsible for finding practical solutions to his or her own problems. The clinician will support and guide the patient to develop creative solutions for change, and they will continually encourage the patient to believe in his or herself that change is possible. In a motivational interview, the patient should be given understanding and non-argumentative feedback regarding their thoughts and feelings, their plans, and their goals. This positive and encouraging feedback can help the patient to feel as if he or she has been understood, and allows them to grow more comfortable in opening up with their feelings and to explore multiple solutions for change. Motivational interviewing enhances a person's confidence through the continuing assessment of their ideas regarding solutions and successes. Motivational interviewing involves regularly affirming the patient's strong points, as well as reviewing past accomplishments and their continuing plans.
Okay, now let's discuss the practitioner's role in actually engaging the patient in change. First off, the practitioner needs to explore and resolve any ambivalence about change in the patient's life. Okay, so we're talking patients now. Okay, we look at the patients. Are they ready to change? How are we going to determine how they're ready to change? And we need to match our intervention with the patient's stages of change. And most importantly of all, we need to clarify what is important to the patient. If it's something that's important to the clinician, it may not be important to the patient. Therefore, it will not be relevant. And if it's not relevant, then you're not going to be able to engage the patient. The trans-theoretical model of change, or any change behavior, it can be evaluated to notify yourself that you're not going to be able to change that patient or get the patient to change during the first attempt. The clinician needs to recognize that there are multiple stages of progression throughout change. For example, the patient may progress and commit to stop smoking, but they may only be successful for 1 day or 2 days and regress back. And this could be because they are not equipped or they do not have the tools to successfully change, or they're not ready to change. When the clinician sees that there's a regression, they should look at what were the mistakes, that could be done differently. And again, going back to the patient's motivation, is the patient motivated to change? If the patient has no motivated to change, then there really is no point in proceeding until that patient has reached that decision point. The trans-theoretical model of change has 5 stages. The first stage is pre-contemplation. Now, when you look at the patient, you need to think about, are they even thinking of changing? Do they have no intent to change in the near future? We are going to see that change. We're going to see that they're not going to be able to change if they do not have some motivation. So when we look at pre-contemplation, we're looking at, do they have the motivation? Are they even thinking about change? If not, we can at least plant a seed and say, at least think about what's happening here. For example, people who have new onset diabetes, they may not want to change. They may be shocked that they have diabetes to begin with. And as healthcare providers, we are very bad about expecting them to change their whole lifestyle in 1 day. So they come into the clinic and we find out their A1C is 10, and we discuss that to them, and with that understanding that we want them to change overnight, it's not going to happen. First off, it's a shock to the patient, and they hadn't even realized that they have a problem. And now we're expecting them to change from A to Z in one big jump, one giant step. That's not going to happen. So we need to start talking to the patient about lifestyle changes. But you need to recognize you're not going to be able to do that in one solid move. So contemplation is when we have achieved some type of change thoughts in the patient's behavior. They are ready to think about changing. So after maybe your 3rd visit with a diabetic patient, they can say to you, okay, I've given up eating syrup for breakfast on my pancakes. That is some type of contemplation, and they've actually prepared to make that change. So when we're looking at preparation, we've already decided, or at least the patient has decided, that they are going to commit to the change. With that preparation, we have action. There has to be a plan for the change to be integrated or implemented in their life, and then we will have maintenance. Now, under maintenance, we also have some problems with regression, and that is normal. So let's talk about pre-contemplation. Smoking, drugs, or other addictive behaviors, alcohol, vaping, overeating, just about anything that is out of control are things that we look at. But again, we want to get that patient to think about thinking. So that's what pre-contemplation is all about. So some things you could say to the patient: are you interested in quitting smoking? If they are a smoker, let's say that they smoke 2 packs a day. You can go into the reasons they need to stop smoking. What are their awareness issues? There's possibility of lung cancer, cardiovascular disease, many other issues that can come because of this problem. You express concern to the patient about their smoking problems. And then this is a catalyst. What would it take for you to become interested in quitting smoking or smoking cessation? This is a thing that we can use as a catalyst to get the patient to thinking about what they can do to change their life, because we are not in control of their life, they are, and we can only make recommendations. We cannot force them to do anything, but we can plant that seed. Think about stop smoking. Think about stop eating so much, especially when it comes to people who are overeating. Overeating is an emotional thing. Actually, addiction of any type is really tied to the emotions. Okay, and then the patient is going to look at the cons and the pros, and the clinician needs to facilitate this thought process. At this point, the patient is not going to want to stop quitting. They're not going to quit smoking. They're not going to do anything because they are not ready. They are thinking about the process of stopping. And again, depending on how many years they've been overweight, or they've been non-compliant with their medicines, or they've been using substances, it may take a while to motivate change. So how does the practitioner help the patient during the preparation stage? Okay, first of all, this has got to be patient-centric. The patient has to be the center of the model here that we're using to facilitate change. This is about the changing the patient's behavior, and we need them to take that first step to change. So when you set up the plan with the patient, you need to talk to the patient what their strengths are. Where have they been successful before? Maybe they used to be a drinker, and they drank 5 beers a day, and they have finally stopped drinking, and now they want to work on their cigarette smoking. Okay, what did they do as a drinker? We're not going to call them alcoholics, but as they were drinking, what was the problem? What helped them change? What helped them catalyze change? So we need to explore what are their strengths to help them be effective, to help them manage the situation, and then how are we going to help be the motivator and be accessible to them. The patient has to commit to change. We cannot do that for them. We will discuss the pros and the cons. The patient needs to recognize what are the pros and the cons. Again, if you don't have the patient motivated to change, it's not going to help. And the action stage is to implement the plan, revise the plan, and help the patient sustain the commitment to the plan. And this is not as easy as it sounds. Let's take an example of somebody who needs to stop smoking, and they have been motivated. They have decided to take that plunge. Okay. So what is the plan? How can we help them be successful? Do we need to order something for them? Now, patches and gum and all the nicotine stuff over the counter can assist in them to stop their goal to stop smoking, but maybe they need something else. Maybe they need a medication. Can they afford the medication? What can we do if they cannot afford the medication? Okay, so we need to make sure that we make a plan that is reasonable, that is productive, and that will help the patient reach their goal. And helping to sustain the commitment to the plan can be very difficult. You have to be an encourager. Okay, so there are 3 components to change. Okay, first of all, the patient has to be ready. They have to see the importance of change. And the third one, which is very, very important, they have to have the confidence to change. You will never succeed in helping a patient change if they lack the confidence in changing. That's, again, going back to explore what their past successes have been. This will help them change because they can see that they can do it again. If they do not have a past success, then we need to help them with small successes along the way. And it may be as simple as, okay, let's take away 1 cigarette per day. Or if it's a diabetic, okay, let's just don't eat white flour tortillas. Let's change it to whole wheat for tortillas. So modifying, maybe take that one step, that modification, one step. It may not be significant to us, but it will be significant to your patient, especially if they like tortillas or white bread or whatever it is that we're trying to get them to change in their life. How do we evaluate where the patient is at in the change process? Okay. First of all, we have to assess the readiness, the importance, and the confidence. So going back to these 3 items, let's think about the scale of 1 to 10, and that we use a scale of 1 to 10 for almost everything. How comfortable are you? What is your pain level? How ready are you to change? That type of thing. So 1 is the lowest point, 10 being the highest point. So we want to say to the patient, how ready do you feel to make this change? If they say they're at 1, then they're not ready. If they're at 10, they're super ready. We want to see around a 4 or 5 because they're partially there or halfway there thinking about the change. Then again, how important is this to you? If they have been diagnosed with, let's say, lung cancer and they're a smoker, it may be very important to them. So again, 1, they're not really wanting to change. 10, they're ready to change. Where are you with this? And then the confidence. Again, they have to have confidence that they can do this. If they feel like they're a failure because they've tried to stop smoking 10 times in the last year, then you need to wait. Where are they? If they're still at a 1, their confidence is going to be a problem, or their lack of confidence is going to be a problem in this situation. Okay, so if the patient decides, okay, you gave them the scale of 1 to 10, and they choose a 5 instead of a 4, that means that they're probably more confident to be ready, or it's important, or whatever it happens to be. But you need to evaluate, you need to explore with them. Why did you choose a 5 instead of a 4? Or why did you choose a 5 instead of a 6? To really evaluate, you need to get to them to thinking about what's going on in their motivation, in their readiness. You need to really lock into are they saying to you. Because if you just kind of, for the better word, ignore really what they're saying to you, you're not going to have good success, and the patient is not going to feel that he can make it by himself, especially if they're at the confidence level of 1. Okay, going back to basic communication techniques, you should use open-ended questions. For example, many times I will ask a patient how they got to a certain situation, like with STIs. Okay, the patient comes in, they have an STI. Tell me about your sex life. And many patients are very open to talk to you about that. And they may have had the same partner over and over again. And that partner may not be faithful, or they themselves are moving from partner to partner. So that would be a problem. But if you try to fill in the blanks for them, to put in the information, you're not going to get an accurate picture. So you really need to open up yourself to looking at these open-ended questions and say, okay, tell me about your drinking habits or your drug habits or whatever it happens to be. And then you might get some good information. Usually after the patient and yourself have some type of trust built, you're going to be able to get good information from the patient. But if they don't trust you and you've not been able to establish that trust, then you're probably not going to make much progress. So if you ask the patient, tell me about your drinking habits, and they may say to you, well, during the weekdays I drink 5 beers. On the weekend I drink 3 tall boys, and I drink some liquor. I have let's see, a fifth of whiskey. So that's what you want to find out. When we do the things like the audit and some of these other tools, we kind of pin them into the tool, and we may not get the information we need. So the best thing you can do before you use the tool is ask them that open-ended question. Tell me about your eating habits. Tell me about your drinking habits. Tell me about your smoking habits, whatever it happens to be. Then whatever they tell you, for example, they say to you, okay, I drink 5 beers every day. Then you're going to say to the patient, and you're hoping that they're being honest with you. Thank you for being honest with me about your drinking or whatever the situation is. And then after the patient continues to talk, you want to reflect back on that, on the situation, what they've actually been told by you and what you have told them, okay? Because sometimes they may want your input. So you may say something to them like, okay, so right now, you cannot make the decision to stop drinking because you feel like you're not ready. And then to clarify, these are the amount of beers you're drinking each night or each day. Is that correct? And then again, you're going to summarize, because if you don't do this, you should be doing this anyway in the clinical setting for any other thing that's not a problem, or maybe the reason that they have the STI or whatever. You need to summarize, okay, so you've had 10 partners in the last 20 days or whatever happens to be the situation. That way you have a better understanding of what's going on. The patient can validate your feedback. Okay, through each step, the patient should be able to validate the feedback. Yes, that's correct. No, that's not correct. And again, we're going back to the partnership. We're going to look at evoking change. We're going to look at being compassionate, and we're going to accept that patient regardless of what they tell us. I used to work a psych hospital, and I did the medical management. I was the hospitalist there. And you have to be non-judgmental, because if for a person to really tell you about their sex life or what they're really doing, they're going to be looking at your nonverbals. So that's also important as well, because if you take a judgmental stance and say you had 5 partners in 3 days, you had 10 partners in 2 weeks, that is going to be a turnoff right there. And the patient is going to say, they're going to shut down. They're going to say, in their mind, they're going to say, nope, this is not working. This person is judging me. So you have cut off your communication. So it's very important to be compassionate, accepting, and remember, you're there to evoke change. You cannot make the change for the patient. The patient has to do that themselves. Things to not do. You do not want to be a dictator. You do not want to be confrontational. You do not want to use shame or guilt. You don't want to threaten them. You're going to, for example, well, if you don't comply with your diabetic diet, you're going to lose your leg. Now, that may be true, but that's not the way to evoke change. Okay, I know a lot of people that actually, providers who actually do threaten their patients with, this is going to be the long term, and you have to be very careful. You could give them the pros and cons, and you can say, these are things that could be happening or happen if this change is not elicited, but you do not go along with that type of threat. If you don't do what I say, this is what's going to happen, that type of thing, because you are not in charge of their health. They are in charge of their health. So when you think about this, look at your own bias. What are you doing? What assumptions are you making about that person, especially when it comes to sexual behaviors? People tend to judge people on sexual behaviors more than anything else, and that includes providers. Okay? People that are broken tend to have extra sexual behaviors that are maybe not acceptable to society because they are broken on the inside, and their acceptance, I just don't know how to find it. Okay? All right, so looking at your own self, evaluating where you're at on the subject matter will make it very easy for you to back off, or you should make it easy for you to back off if you're being over dramatic or over controlling. The thing about it is, we have to go back to that patient-centered model. What would the patient like to talk about? You might want to talk about their drinking today, but they just may want to talk about their troubles. Okay? You need to know what is important to the patient, because if you don't focus in on that, the patient is not going to be receptive. Okay, so once change is elicited, we evoke change. How do we keep this change going? Does anybody have any thoughts or questions on that? How do you keep the change going? How do you maintain that current state? Let's say the patient has successfully stopped drinking. What can we do to keep them at that level? Any thoughts or comments? Okay, so what we want to do is we want to support them. We want to go with the plan that we've already developed if it's working. Okay, and again, going back to the patient, what is going on in your life? How can I help support you? So you do that by just having an honest conversation with the patient. Okay, again, remember they can regress at any time. So if they've regressed, then all you do is talk to the patient, find out what the details of what happened, and then maybe you need to modify your plan. So, can the regression or the relapse be prevented? Again, support from the provider is a key thing to helping motivate change. Any thoughts about this situation, relapse or regression? Okay. How does this apply to healthcare? I've discussed, and Dr. Goddard and I have discussed the situations that we find in healthcare. We've talked about the diabetic patient. We've talked about people who drink, people who have sexual behavior we may not approve of. Okay, there's substance abuse. There's all kinds of different situations. I think the ones you're going to find most in primary care are probably going to be helping a patient who's a newfound diabetic or one who's has a chronic condition like hypertension or anything like that. Help them manage their care because there may be a reason they're not compliant. If they have hypertension and they ran out of their pills, or they have pills and they don't want to take them, you've got to research into that. You need to talk to the patient, find out what's going on. Maybe they don't have the money. Maybe they don't like the side effect of the pills, but they didn't want to tell you because you're the provider. And so there's many issues here. But we have people that with the chronic diseases, a lot of times they're not compliant, even after they've lost limbs. And sometimes it could be lack of understanding. And remember that you have to be at the patient's level of understanding. You can't just be up there and use all these medical terms. I'm very cognizant when I'm in the clinic, what does the patient understand and what do they not understand? And so you have to explore what's going on with them. And if you find out that they're in an abusive situation, this could be part of the problem. Domestic violence is a big problem in today's world. It's now called domestic violence is now considered one of the number one problems that we have, and people are afraid to talk about it because they may be threatened. And think about, how do you know if somebody is abusing their spouse or they're getting abuse at home, whether it's the patient is elderly or whether it's the interpersonal violence between spouses or friends or whatever. So it's very important to think about how you can apply this to healthcare. It's almost any situation you can think of, you can apply this. Okay, now we're back to the end of the situation here. As far as I am concerned, we are finished with this video. Dr. Goddard, do you have any comments, thoughts? Does anybody else have any comments, thoughts, questions? This is a time to ask.